lot of, obviously, colon resections, low pelvic cases, but we also, kind of by extension, tend to do a lot of complex hernia cases too, just because, you know, patients who have colorectal problems tend to have big hernias too. So anyway, this is a lecture on just the ERAS stuff and what it's about and what we're doing with it. It's a totally original lecture by me, as you can see. Dr. Thomas had nothing to do with it. It's all my original thoughts. So basically, what is ERAS? Basically, this is the technical definition. But basically, I think the best way to think about this is it's a systematic approach to patient recovery. Is, you know, that basically there are lots of little components, and I think that's best shown on the next slide. Like, here's all the bits of it. You know, no one of these things is ERAS. They're all together. You know, and I think the theme you're going to see over and over again here is that a lot of what they've found is that when you study these various interventions individually, you will see a small effect or no effect. But when you pool them and use it as sort of a systematic approach where everything's going at once, you see big effects. And so I think that, you know, that may be due to a couple things, but I think a lot of it is that, you know, we just don't know which interventions are working on which people, you know, and we probably don't have studies powered enough to pick up, you know, a 1% change. But when you add up, you know, 21% changes, it's significant. So I think that that's kind of where it comes from. So on the slide you can see here the different colors, which are to signify, I think everybody here is floor nursing, right? Nobody's OR or... Oh, OR, okay, there we go. So, good. All right. And pre-op, good. So that's good. So that's actually even better. Because as you can see, the red stuff is pre-op. That's all what's happening before the surgery starts. The orange stuff is intra-op. That's all the parts that happen there. And then the green stuff is post-op. And so again, it's a multi-stage process where you're doing these things across the whole institution. This is a funny slide from Alice in Wonderland, which typifies a lot of these sort of interventions and the importance of, you know, what are we trying to do here? Basically, why is it needed? Basically, there's three main benefits. One, we want to decrease post-operative complications. You know, we want people to not have adverse events when they're having colon surgery. And we know that colon surgery is a great place to target and start all this because colon surgery is high risk. You know, you're dealing with a bacteria-packed pipe. And so, you know, compared to most things, colon surgery has a lot of wound infections and complications. So, and if you're going to implement a system that's going to make people have less complications, go where there's already a lot of problems. It's easier to show an effect. You know, you're going to have a hard time showing, you know, improvement in a lap choles because, you know, they all do fine anyway. So decrease complications, shorten length of stay, and basically just improve their recovery. And there is a lot of evidence that we do these things when we do these sort of interventions. Barriers for implementation. Basically, you know, why do doing these packets of interventions not work? Basically, you don't want to turn this into a checklist or a cookbook, you know, because people already have enough forms to fill out on their average shift, and so we're trying to not add to that. We're trying to make this more of an easy to do process. You know, and then, you know, there's also some of the components haven't been proven individually, so there's sort of a, well, you know, why am I doing this? Is this actually doing anything? You know, it's only been proven as part of a big study. You know, and then there's patient factors too. I mean, some you all know, some people don't want to go home early. You know, some people don't want to go home, period. So, you know, there is some, you know, there is some of that you're going to run up against here, and you know, and that is real, and I think it requires a lot of patient education to, you know, like, you know, we're trying to get you home because we're improving your care. We're not kicking you out of the hospital. This isn't like, you know, we're not saving, you know, this isn't about like, you know, making more money off of you. You know, sometimes people have those perceptions too. So basically we've talked about, you know, basically it's a culture of recovery. The point is what the best outcomes for patients, the best outcome is that they come in, they have their procedure, and they go home quickly, you know, and this is well known. We don't want them sitting around getting DVTs and pneumonias. We don't want them picking up MRSA and passing it along to everybody else. We don't want them to sit on the floor with an NG tube and an ileus for a week, you know, like that's not good for anybody. And so basically that's where our goal is. And a lot of this comes from some old-fashioned practices, and a lot of this comes, you know, top-down from surgery. You know, like for instance, you know, a couple decades ago even, I mean, I think this has gone away more recently, you know, standard practice was every patient with bowel surgery got an NG tube, and don't you dare give them a cup of Jello until they're, you know, farting the national anthem, right? You know, that was like, you know, dogma, and, you know, God help you if you changed it, because you're gonna, you know, but a lot of these things have slowly gone away, and now we're sort of, you know, pooling that together and taking a group approach to, you know, fixing it. So we'll get into some of the nitty-gritty here. So what are some of the preoperative elements? This is stuff that's happening, you know, either in pre-op or in our clinic, most likely, is, you know, smoking cessation, we know is a risk factor, uncontrolled diabetes. Another big change has been minimizing fasting periods, and this comes from work with anesthesia where they found that you don't really need to be NPO at midnight for everything to safely have general anesthesia. You shouldn't have a breakfast at Denny's an hour before, certainly. But what they found is that clear liquids are actually totally fine up to 2 hours before general anesthetic, and that does not increase aspiration risk. So what we're doing is we're starting to tell patients, like, you know, when you get up in the morning, go ahead and, you know, have a glass of juice if you want, or, you know, some black coffee, and that's fine. And then just stop drinking. We target about 3 hours before surgery in case we're running ahead, which we hope we are. And that, you know, reduces the fasting time. So basically the goal here is keep their gut working. You know, don't starve them, and then, you know, their gut won't shut down. The other preoperative elements are multimodal anesthesia, analgesias. You know, the idea is giving them anti-inflammatories, giving them Tylenol, using local anesthetics. Bowel preps, you know, there was some work in the literature for a while on not doing the full mechanical and antibiotic bowel preps, but that didn't pan out, and so we are doing those still. But I think that we've adjusted them a little bit to where we're able to, what we do most of the time is a high dose of Miralax and, you know, a bottle of Gatorade for their prep. And so rather than chugging a 4-liter jug of the Go Lightly, they're using a concentrated Miralax and Gatorade, so they're getting more sugar and electrolytes, so they're not coming in as dehydrated. You know, we're not as far behind the 8 ball. So, and then of course patient expectations. I tell everybody, you know, the goal is you're going to get out of bed the day of surgery, you're going to eat that night, and you're going to try and go home the next day or the day after. You know, and you guys know this from nursing. I'm not telling you anything new here, that expectations are a huge part of what patients, you know, how well they'll do. You know, if you tell someone they can walk, they can walk. If you tell someone that they're too weak to walk, they won't walk. You know, like there's a huge component of what's supposed to happen. Intraoperative elements. So we've gotten away from using as many intraoperative narcotics. Part of this is the pre-medication that we talked about. A lot of this is using local anesthesia, but an even bigger part of it is you know, Dr. Thomas and I being aggressive about using laparoscopy and robotics as much as possible. You know, if you don't make a foot-long incision, they don't need a lot of narcotics, and if you don't need a lot of narcotics, they don't get an ileus. So this stuff works together. We also treat nausea aggressively. We minimize intraoperative fluids. We'll get back to that later, but fluid restriction's been found to be another big key part of this. And then we do post-op high-flow oxygen. So basically, everybody who comes out, they get a face mask oxygen for 6 hours. and then we remove it. We also use wound protectors. They're little plastic sheaths that go over the wounds. We use closing tray or the equivalent, which is just clean instruments, gloves, etc. We're trying to minimize contamination, etc. Post-op elements, standard mobilization. Basically, we want people up and moving. One big change that we've been able to implement that I think works really well is having patients transported to the floor. We instruct PACU, they go to the floor in a wheelchair, not a bed. Okay? So basically what that does is it sets the standard in the patient's mind and the floors that, okay, you can walk because you already did it. You know, so basically it's like, okay, time to go upstairs. All right, stand up, get in your wheelchair, and then go upstairs. I mean, we're not requiring them to do jumping jacks or anything ridiculous. They did just have anesthesia, but most patients, there's no reason they can't stand up out of a bed and get in a wheelchair. And we found too that when they get upstairs then, a lot of times the floor nurse can ask them, okay, do you want to lay in bed or do you want to just sit in a chair here? So they can just sit up and watch TV. And so I think it sets it in everybody's mind that it's okay to move, you know, that we're not waiting on something to get out of bed. And then discontinue barriers to self-mobility. You know, Foley removal, drain education. Again, we're trying to get these things out quickly, get patients comfortable moving with them. We talked about early patient-directed enteral exposure. So basically that's a fancy word for eat what you want. Patients, of course, in PACU, they'll start by getting like crackers and juice and Fulls if they want it, whatever sounds good to them, and then we kind of let them direct their diet, you know. If you're already queasy, giving someone beef broth is not always the best solution, you know, like that stuff's disgusting, I think, and I wouldn't drink it when I'm not nauseous. So, you know, now, but I've had patients who love it though, who like request it. So I think that letting patients pick what they want to eat, telling them, okay, what sounds good to you, what do you want to eat, use the menu, pick and choose, they will tend to eat more and faster if they get to select what sounds good to them. And then, of course, minimizing narcotic exposure. We know that, you know, opiates are a huge factor for post-op ileus, and, you know, I mean, opiate crisis, it now has a buzzword, and there's like a graphic on the evening news, so, you know, it's become a big thing. But, you know, we've known this for a while, that patients who lay in bed and take a bunch of narcotics don't go home quickly. Patients who don't take narcotics and get out of bed do. And then the last thing is with IV fluid administration is basically, we'll get back to some of the evidence on that, but the best way to minimize fluids is to have standard turn-off times, you know, and just say like, so most of the time what we'll do is we'll say, okay, we're going to run LR at 70 an hour for 6 hours and then turn it off, you know, and that's the easiest. And we did 6 hours because the evidence on the high flow oxygen is also 6 hours. So basically it's one intervention, like, okay, here's my 6 hour mark, go in, unplug the oxygen, turn off the fluids, you know, tell them to take a walk, give them dinner, you know, so you can kind of pool these things. So basically trying to do order sets that are based on literature. So basically instead of doing slow progression from ice chips to fluids, the idea is clear liquids, full liquids, day zero, solids as they want. And usually what you'll see is, you know, the first case of the day, which is done by 9:30, 10 o'clock, they'll probably eat a solid dinner. You know, if we're doing 3-4 cases that day, then okay, maybe, you know, crackers that evening is the best they're going to do, but it, you know, you basically let them direct it. We talked about, you know, PACU, ward, home, ambulating, get out of bed and move. This doesn't work in the United States, but I saw a lecture, I remember this years ago, where they were talking about this hospital in Britain where they implemented a lot of this early recovery stuff. And what they did was they designed the ward such that there was a common area at the end of the hall that had tables, and they would, all the food that they ever served was in a buffet at the end of the hallway. So they would never bring any food to the patients' rooms. So they all had, if you were hungry, you had to get out of bed and walk down and eat the food. I doubt we could ever do that in this country, but it was, but it works really well. I mean, because it's basically like you're not getting food unless you go walk down there and get it, and you know, so it's amazing how many people could walk with you. And then investigations. This is part of it too, is that in doing all these interventions, what we found is that because we feed everybody right away, because we're doing minimally invasive surgery, because we're controlling pain, the standard discharge time has become post-operative day 2 in the morning, possibly post-operative day 1, sometimes they stay a little later till 3. But what that's done is, Thomas and I have found, is that it makes it easier for us to identify when a patient's having problems, So because we expect them to get well and go home early, if post-operative day 3, their belly's bloated, they're throwing up, they look sick, they're not doing well, we don't wait it out. We're like, okay, there's a problem. Let's study them for a leak. Let's, look for pneumonias. Let's figure out what the issue is. Rather than, the old way, and this is the advantage of doing it this way, is, the old way, if they had an NG tube in and you're waiting for them to pass gas, a person bloated on post-operative day 3 was standard, so it wouldn't necessarily cue you into something. So a lot of times, in the rare event that we do have a leak or a problem, we usually can pick it up early. I mean, sometimes even on post-operative day 2, I've been able to identify, okay, this person's having a problem, they're not where they should be, let's figure it out. And I think that makes a big difference too. And then Foley's, basically removing them on post-operative day 0 or 1, so we tend to get those out, same day, if not the next morning. There's the one exception would be if we do like really low pelvic cases, like where you're doing like a true like total rectal resection, coloanal anastomosis. We'll often do a post-operative day 2 Foley on that. There are also, if they have like a diverticulitis where they've got like a colon fistula to the bladder, sometimes they'll go home with a Foley. So there's exceptions to all this, but usually they don't need these things for long periods of time. Pain control, we talked about multimodal pains, and then IV fluids, basically restricting them. So we'll get on to more of the fluid stuff. There's a Shakespearean quote up there for you. Basically, a lot of the evidence recently has shown that IV fluids can be too much of a good thing. Patients who are dehydrated, obviously we know they don't perfuse their gut, they feel lousy, they can get tachycardic, hypotensive, that's a problem. We've all known about that forever. But increasingly evidence has shown that you can go too far the other way. If you overload people with fluids, well, they get edema, right? Well, everybody's seen the patient who's been over-resuscitated and is puffy and swollen everywhere, right? Well, that's not restricted to your skin. Okay, that happens everywhere in your body, your gut's no exception. So when the bowel gets puffy and edematous and swollen, guess what? It doesn't work. And so that is a huge part of why these patients aren't eating or moving, is because they are edematous and swollen and nothing's moving anywhere. We talked already, and a lot of this is review over and over again, it makes it easier to remember, but basically letting them have clear liquids up to 2 to 3 hours before surgery. We restrict fluids intraoperatively, usually they don't need it. And then, basically isolated oliguria is not an indication for a fluid bolus. Most humans go 8 hours without peeing. It's called sleep. So it's okay. Most people are able to do that about once every 24 hours and they do fine. And so a lot of this data, which has been accepted as surgical dogma, is being revised, and so, the old indication, like, okay, you have to make 10 cc's of urine per kilo per hour, right? Well, a lot of that, if you dig back, a lot of that data came out of Army data. It was battlefield data based on soldiers having traumatic, bullet and shrapnel injuries and having huge open surgeries, and that was the indication. Not only is that a different scenario than what we're doing, that was also from what battle? The Korean War. So that was 60 years ago. So it's okay to revise some of that. And so a lot of us are, as long as patients aren't, I think urine output is seen more as one of a constellation of findings. Now obviously if a patient is hypotensive, they're tachycardic, their creatinine's rising, then yes, there's probably an indication for a bolus. However, the urine output is low. Well, are they drinking? Yes, they just had dinner. Are they walking around? Yes. Is their blood pressure and heart rate normal? Yes. Well, then no, we don't need to bolus fluids. We just need to let them eat, and their kidneys will sort it out, and more often than not. And so we talked about unrestricted access, and then doing the IV fluid 70 cc's per hour, and then discontinuing 6 hours. That's just a random number that works out well, And again, some of this fluid stuff works because they're not coming in dehydrated. Again, we talked about lower volume bowel preps. We talked about letting them drink the morning of, restricting, all these things add up, again, and that kind of gets back to the beginning point I made about ERAS being, none of this stuff is happening in isolation, and so it cumulatively works. This is things we tell, I joke with patients, Dr. Thomas is more succinct than I am, but we both say a version of this to everybody, like, yes, it hurts, you just had an operation, so,
Preoperatively, do you recommend giving the couple days before carbohydrates and things like that? Because we had been giving drinks and things like that, and I don't know if...
I think it's a great thing. I mean, okay. I think there's a lot of data also on carbohydrate loading and these surgical recovery formulas that are out there. Now, again, and this gets back to the barriers to implementation, where does it come from, who pays for it, has been often a barrier to that. Yeah. But I think that we're working more with the hospitals on getting that available to patients, and I think it's a great thing, especially because they have to do a bowel prep. If you give them these carbohydrate drinks, they don't feel as hungry while they're doing it because they're getting something in there. So I think that's a great thing.
We have been giving it in pre-admission testing. We go ahead and just give them the preload.
Right. And I think that that's a great thing. Again, it keeps them in a fed state, sort of speaking. So basically what's happening is they're only really fasting for a couple hours before surgery, and then they're eating right after. I mean, a lot of times we're doing robotic cases, you can watch the bowel peristalsing while we're in there working. I mean, the bowel almost never is, sometimes it doesn't even shut down, it just kind of keeps fairly active. So we talk about pain. Which is kind of the bane of existence of surgery. But, again, it's a mental attitude. Yes, it hurts. You just had surgery. That's expected. But pain control is seen, I think, best as more of a functional question than a regular question. I think the 1 to 10 pain scale is something that's, no one can make it go away. Is it beneficial? No. I don't think it's useful or helpful to anybody. It's BS is what it is. But that's my more candid view. I think the question for patients should be like, okay, yes, your wound hurts, but here's the problem. What does hurt mean? Well, it's different for everyone. I mean, one person's 10 is another person's 1. It's impossible to know. So I think the more useful question is to ask these patients, okay, it hurts. Can you get out of bed? Can you eat? Can you walk? If the answer to all those questions is yes, then your pain is well controlled. If the answer, if you're like, you can't sleep, you're moaning, you can't move, then your pain's not well controlled. And it doesn't really matter what number you assign to that. So I think that, focusing more on function rather than pain is a better way to treat it. Again, a lot of what we do is multimodal. So we put people on scheduled Tylenol, we put them on scheduled Toradol. We use local anesthetics, anesthesia does tap blocks. So we do everything in the world to minimize, IV narcotics. And then post-op, we do make narcotics available because people are going to have pain and they're going to need help with that. But I think it's important, and this is where the team approach and you guys come, is it's worth asking patients what their complaint actually is. If a patient says, I can't sleep, that's not, narcotics are not sleep aids. That's not, well, why can't you sleep? Well, if I'm worried about this or I'm feeling nervous or whatever, well, maybe an anxiolytic would be a better choice, or maybe a sleep aid would be a better choice, A lot of times, I was just in the OR the other day, we were talking about this, that some of these patients who wake up from surgery and they're moaning and groaning and PACU and thrashing around and they're having all this pain. Some of these patients, you can give them all the fentanyl in the world and they won't calm down. You give them like 2 of Versed and they're fine. So a lot of times it's not a lot of pain is, as they say, supertentorial, so sometimes an anxiolytic or a sleep aid or something like that is going to be a lot more effective than just more narcotics, and so I think that, again, with PO narcotics, they're there if we need them, but it's based on, I can't get out of bed, I can't do the things I need to do. Okay, that's a reason to take a narcotic so that I can function, not to make my pain score 0, because that's probably not a realistic goal anyway. No one ever goes to 0 after surgery, Narcotics don't work that way, and we all know that.
What do you usually utilize for a sleep aid for your patients? It probably varies if they're night.
We'll let them have, they can try Benadryl if that's available. They could also do Ambien. Some of them already come in taking trazodone every day, so we'll reorder that, So I think that, again, getting to the root of what their complaint is often helpful. Everyone will pass out if you give them a slug or Dilaudid, but, sometimes that's not.
You say everyone.
Well, okay. And so discharge criteria, again, trying to get them home, so what are we aiming at? Basically, we want them eating, we want them, controlling their pain with oral analgesia, passing flatus, or their ostomies putting out, a decent amount of stool, and they're walking around. Again, they don't have to be having formed stools. And I tell patients this too, they say, well, when am I going to go home for my surgery? And I say, well, when you're ready, here's the goal. And again, it's education on my end and your end is telling them there's no magic number of days that you need to be in the hospital. This is based on, are you eating? Is your bowel starting to work? Are you walking around? Is your pain controlled? If you're doing those things, you can go home. If you do them all tomorrow at noon, go home tomorrow at noon, So I think that making it more of a goal-directed thing rather than a timing thing helps, and I think the computer just died.
How do you go back on him?
It's on him, it's just that his computer's dead.
Oh.
Okay.
Let
So,
me go grab a charger.
I'll try to remember what the rest of the slide said, but I think I've covered most of the main points, but I have a copy of my slideshow in my email, so I'll just look at it real quick, make sure I didn't forget to say anything, and then we'll go from there. So questions, what do you guys?
One of the things we've been doing with some of our GI surgeries is IV Tylenol. Is that something we've been doing 2 doses post-op?
Yeah, I think it's a great idea. I mean, I think that, again, a constant debate with some of these things. I was actually almost on the last slide. So.
Oh, you were?
Yeah,
Okay.
but that's okay. So we're good. I think that, giving them a couple doses post-op of IV Tylenol is a great idea. Yeah, I think that, again, you get into costs and, availability issues, but I think that if it's available, and I think what the compromise that's been reached is, the pharmacy department looks at their budget and they're like, okay, you can't put people on this for 3 days, this is too much. And we're looking at it like, well, come on, let's do everything we can. So I think the compromise position in a lot of hospitals has been, okay, you can have this many doses and then they have to take pills. And that works pretty well. I mean, usually, 2 doses of Tylenol will get them to the point that they're probably eating solid food anyway. So I think that that's reasonable. The last slide, which may or may not end up being pictured, basically just says what's in it for me. So why is this important to you guys as nursing staff, versus just us, getting our patients home sooner and not having to round as much. Basically, the idea is to make these patients, one of the side effects of doing all this is that I've noticed is that I don't tend to write a lot of orders on my patients when they're on this pathway. I tend to write a bunch of post-op orders, and then I check labs every day and write a discharge, if this works. So I think that the advantages here are that by trying to do early recovery, by putting these things in motion from the get-go, a lot of these times these patients kind of autopilot and then they go home quickly. And I think the goal for nursing, especially on the floor, is that it shifts your workload from doing checking things off XYZ to communication and education with the patients, which I think is a better, more rewarding system. So you're spending more time talking to them and educating them, and less time, flush the NG to administer this, change that, less of that stuff. So I think that overall that's kind of the goal. Yes.
Ostomy care. So if you have a patient and the patient's going to have an ostomy, when do we start the are they prepped even before surgery, some of the
I think-
education, and how will that flow? I just want to know from a hospital standpoint, where we fit in and what that looks like.
Right. Well, I think that, and we were talking about this just before this meeting started too, is a couple of us that a lot of times nowadays, especially on the elective cases, we usually do know that we're going to do an ostomy before we do it. Now, there are unexpected ones and that happens, but most of the time, if we're doing a rectal cancer and it's in the middle of the rectum and they've had radiation before, like we know going in they're going to have a loop ileostomy. So that's part of it, is predicting it. The second thing is we try to send them to wound care clinic or beforehand, if that resource is available. I think if they can get marked ahead of time, that's a good time for education too. And then you're right, after that it's just post-op education. We encourage them to learn it as fast as possible, be involved, if they're up out of bed and doing these things, then I think that helps,
Yeah.
So I think you're right. I mean, I think that the more pre-education you can do, the better, if there's a wound care clinic available, that's useful, but otherwise a lot of it ends up on, the post-op end of things.
Is your belief or philosophy that the patient will be involved from the get-go post-operatively with their ostomy?
No, absolutely. I mean, I think that I tell them all the time, I'm like, no, this is not the nurse's job to empty your bag. This is you, okay? You have to do this. This is, and I tell families too, especially with elderly patients, and I think that's an important education point, and so we're all on the same page saying the same thing, is like, listen, you have to help take care of this. The more involved you are, the more likely they are to be independent, So yeah, I think that, changing bags can be hard, especially, that's something they have to learn. Anyone can empty their ostomy bag into a basin, okay? That is not a technically difficult task. You have to be extremely disabled and ill to not be able to do that. So I think that, telling patients, no, you need to do this, will help you, but you have to do it, is a great step.
How soon do you want the wafer to be taken off of the skin and actually have that area assessed after surgery?
Well, I mean, ideally probably post-op, you might just do it in the evening, post-op day 1 or 2. I mean, usually wafers don't need to be changed more than every 2 or 3 days, but I think there's an educational benefit from changing it, more than anything else. And frankly, Thomas and I don't do as good a job putting them on as the nurses do anyway, so